Welcome to the deep dive. Today, we're really getting into the nitty-gritty of how our bodies stay in balance. Fluids, electrolytes, acid base, that kind of thing.
Yeah, and not just that, but how healthcare folks keep things safe during, say, IV treatments or surgery. Plus, tackling infections, which is always a challenge.
Exactly. We know you want to get a solid handle on this essential stuff without drowning in details, and, well, that's our plan.
We've pulled together insights from chapters 9, 13, 14, 15, and 19. And what's really cool is seeing how they all, link up. It's not separate silos.
Right, it's all connected, like gears in a machine.
Precisely. So our mission here is to pull out the absolute must-knows, maybe some surprising facts, so you feel genuinely up to speed on these core healthcare topics.
Okay, let's jump in with Chapter 13, Fluid and Electrolyte Balance. It's kind of amazing how many body parts are involved in just keeping this steady.
Oh, absolutely. It's like a constant balancing act. Yeah. The kidneys are huge players here. They filter waste, manage fluid volume, and kick off this hormone system called RAS.
Renin-angiotensin-aldosterone system.
That's the one. It basically controls fluid and blood pressure, influences electrolytes too. Then your lungs, they manage the acid-base side by breathing off KOs.
Okay.
And your heart and blood vessels, they circulate everything, obviously, but they also tell that RAAS system when to, chill out a bit.
Makes sense.
Then you've got the adrenal glands making aldosterone that tells your body to hold on to sodium and water. The parathyroid glands handle calcium and phosphate. Even your gut is involved, absorbing the water and electrolytes in the first place. It's quite the collaboration.
And it's not just how much fluid, but where it is in the body.
Right.
Different compartments.
Exactly. Most of it, maybe 70%, is intracellular inside the cells. The rest is extracellular outside the cells.
Okay.
And that extracellular bit is divided into interstitial fluid, which is kind of bathing the cells, intravascular fluid, that's your plasma, and then smaller bits called transcellular fluids, like spinal fluid. Knowing this helps understand how problems show up.
Gotcha. Now, electrolytes. These little charged particles seem like a really big deal.
They really, really are. Take sodium, normal range is about 135 to 145.
Oh.
Think of it as the main controller of fluid outside the cells. Super important for nerve signals, too.
Okay, sodium outside.
Then potassium, that's 3.5 to 5.0. It's the king inside the cells. Critical for your heart, your muscles. Even small changes here can cause major issues.
Wow.
Calcium, 9.0 to 10.5, bones, blood clotting. And interestingly, it needs vitamin D to be absorbed properly. They're like partners.
Right, vitamin D.
Magnesium, 1.3 to 2.1, is another workhorse for nerves and muscles, especially the heart muscle. And chloride, 96 to 106, links back to that acid-base balance we mentioned.
So it's a delicate balance. And things can get out of whack.
Yeah, definitely. You can have fluid volume deficit, basically dehydration, or more severely hypovolemia, meaning low blood volume.
Or the opposite?
Yep. Fluid volume excess, overhydration, swelling, what we call edema. And then, of course, all the electrolyte imbalances, too much sodium, too little potassium, hyper this, hypo that.
So how do doctors and nurses actually spot these imbalances? It's not like a warning light goes off.
No, not usually. It's more like detective work. You start with the patient's history, what they normally drink, how much they pee, any meds like diuretics, any recent vomiting or diarrhea.
Okay, the background story.
Then vital signs. Low blood pressure could mean fluid deficit. High blood pressure might mean excess. An irregular heart rhythm could be a potassium issue.
And just looking at the patient can tell you a lot too.
For sure. Swelling, edema, sudden weight gain that screams fluid excess. Remember, a liter of extra fluid weighs about a kilogram, roughly 2.2 pounds.
Oh, that's a good rule of thumb.
Conversely, dry mouth, skin that kind of stays pinched up, that suggests dehydration, fluid deficit, muscle twitches or weakness, could be electrolytes. And there are specific signs, Chvostek's and Trousseau's, that point right to low calcium.
And then the lab tests give you the hard numbers.
Exactly. Serum electrolytes are key, obviously. But also things like BUN and creatinine on high levels often mean the kidneys aren't working well.
Which messes everything up.
Right. Hematocrit, the red blood cell percentage, might look high in dehydration just because the fluid part is low. Urine-specific gravity shows how concentrated the urine is high means the body's conserving water. And ABGs, arterial blood gases, give that acid-base picture, which is all tied in.
You mentioned age. Why are older adults more at risk for these problems?
That's a really important point. Their kidneys often don't concentrate urine as well as they used to. Their sense of thirst can decrease, so they might not drink enough even when they need to. Plus, they're often on more medications, polypharmacy. Diuretics, laxatives, blood pressure meds. Many can affect fluid and electrolytes, and they're more likely to have things like heart failure or diabetes, which adds another layer of complexity.
So what can people, especially older adults, do to reduce their risk?
Education is huge. Staying hydrated maybe 2 to 3 liters a day unless a doctor says otherwise. Knowing the signs of dehydration and overhydration. Understanding their medications, why they take them. Potential side effects like fluid shifts. Eating a balanced diet with enough electrolytes. Maybe limiting caffeine and alcohol, which can dehydrate you.
Self-monitoring too.
Yeah, keeping track of weight daily, maybe blood pressure. Noticing dizziness, swelling, confusion, and reporting those things early.
And if an imbalance does happen, what's the nursing care plan look like?
It really depends on the specific problem. Could be IV fluids or maybe fluid restriction, replacing electrolytes, maybe giving diuretics for fluid overload, always watching closely.
Lots of monitoring.
Oh yeah, tracking intake and output, daily weights, labs. If potassium or magnesium are off, monitoring the heart rhythm is critical. Checking neurological status, especially with sodium problems, and always teaching the patient, reinforcing why they need fluids or maybe less fluid, why meds are important, what to watch out for.
Could we touch on a few specific electrolyte issues again, sodium, for instance?
Sure. With both low sodium hyponatremia and high sodium hypernatremia, you often see neurological symptoms first. Confusion, sleepiness, maybe even seizures or coma in severe cases.
Scary stuff.
It can be. Treatment involves finding the cause, adjusting fluids carefully, maybe giving or restricting sodium.
And potassium, you said that affects the heart.
Big time. Low potassium hypokalemia or high potassium hyperkalemia can cause muscle weakness or cramping, but the heart is the main concern. High potassium is especially dangerous. You can see these tall, peaked T waves on an ECG,
Wow.
which can warn of serious heart rhythm problems, even ventricular fibrillation. And a crucial safety point, you never push IV potassium quickly. Always infuse it slowly, carefully.
Got it. Never push potassium. What about calcium and magnesium?
Low calcium hypocalcemia can cause muscle spasms, tingling, sometimes seizures. Treatment is often calcium, maybe with vitamin D to help absorb it. High calcium hypercalcemia might cause nausea, bone pain. Need to find the cause, monitor the heart.
And magnesium.
Low magnesium hypomagnesemia can cause jumpy reflexes, seizures. High magnesium hypermagnesemia, often linked to kidney failure, can cause drowsiness, slow heart rate, low blood pressure. Treatment depends on the cause, might involve giving calcium or diuretics for high levels.
Chapter 13 had some really practical takeaways too, didn't it?
Yeah, definitely. Like how body water changes with age and gender, needing more fluids when it's hot or you're sick or exercising, reading food labels for electrolytes.
Simple but important.
Right. And remembering illness increases risk. Older adults are higher risk. Asking about meds that affect balance. Scheduling fluids for people who can't easily get them themselves. Knowing that minimum urine output, 400 to 600 ml a day, shows kidneys are doing something.
More monitoring points.
Yes, watching heart and lungs closely during IV fluids for dehydration. Checking foresights hourly if potassium is running. Realizing rapid weight gain is the best sign of fluid retention. Watching for those ECG changes with high potassium. And working with dietitians for special diets.
That's a great foundation. Let's switch gears slightly to Chapter 14, acid-base balance. Those ABGs, arterial blood gases, seem complicated.
They can seem that way, but they give such a vital snapshot of your body's internal chemistry. Usually drawn from an artery radial and the wrist is common, sometimes brachial or femoral.
And that Allen test.
Ah, yes. Crucial before using the radial artery. You basically check if the other artery in the hand, the ulnar, can supply enough blood if something happened to the radial. Safety first.
Okay, so you get the blood gas results. pH, PACO, H2O, PTO. What are the numbers we're looking for?
Normal pH is tight, 7.35 to 7.45. PACO, that's carbon dioxide managed by the lungs, should be 35 to 45. H2O, bicarbonate, the metabolic buffer from the kidneys, is 22 to 26. And PACO oxygen level, ideally 80 to 100. Below 80 means hypoxemia.
And this idea of compensation uncompensated, partially fully compensated, what's that about?
It's how the body tries to fix an imbalance. Think of pH as a seesaw. Campinuros, lungs, and bicarbonate kidneys are on opposite ends. If one side is too heavy, the body tries to adjust the other side to level it out. Okay.
Uncompensated means pH is off, and only one of the others, CO or bicarb, is off too. Partially compensated means pH is still abnormal, but the other system is starting to help, so its value is changing too. Fully compensated means the body worked hard, got the pH back to normal, but both keto and bicarb will be outside their normal ranges to achieve that balance. And the different imbalances themselves, metabolic versus respiratory acidosis or alkalosis, they cause different symptoms.
They too often linked to how the body is trying to compensate. Metabolic acidosis. You might see deep, rapid breathing, small respirations as the lungs try to blow off extra co-euro.
Trying to raise the pH.
Exactly. Metabolic alkalosis. Breathing might slow down to hold on to co-euro. Respiratory acidosis, often from poor gas exchange. Headaches, maybe increased pressure in the skull. Respiratory alkalosis, usually from hyperventilating. Tingling, lightheadedness.
Chapter 14 also had some core concepts to remember, right?
Absolutely. Lungs control POO, kidneys control bicarbonate and hydrogen ions. They compensate for each other. Acidosis generally makes nerves and muscles less excitable. Alkalosis makes them more sensitive.
Priorities in care.
In acidosis, check the heart first risk of hypotassium and arrest. For acute respiratory acidosis, airway is number one. Always think about fall safety with any imbalance due to potential confusion. Monitor neurostatus closely. Check ABGs to see if treatment's working. Watch potassium in acidosis. And patient teaching on med compliance is key, as some drugs can cause imbalances.
Okay, let's move to Chapter 15, infusion therapy. Sounds straightforward, but there's a lot to it.
There really is. It's basically giving fluids, meds, blood, or nutrition, usually IV, but sometimes other routes too, into bone, under the skin, into the abdomen, even near the spine.
And why is it used so much?
Oh, tons of reasons. Fixing dehydration or electrolyte issues fast, giving meds that don't work orally or need to act quickly, nutritional support like TPN if the gut isn't working, blood transfusions, emergency access, long-term treatment for chronic stuff. It's versatile.
Safety must be paramount.
Absolutely critical. The 7 rights of medication administration always apply. Checking compatibility, you don't want fluids or meds reacting in the tubing. Aseptic technique, keeping everything sterile, is non-negotiable. Watching closely for problems like infiltration.
Where the fluid leaks out?
Yeah, into the tissue, or phlebitis, vein inflammation, air embolism, fluid overload. Using infusion pumps, especially for high-risk meds like potassium or insulin, is standard practice now for safety.
And preventing those bloodstream infections from IV lines, CRBSIs. What's the drill there?
It's a bundle of things. Hand hygiene, obviously, before and after touching anything. Using chlorhexidine to clean the skin before inserting and for dressing changes. Strict sterile technique for insertion and care. Changing dressings, regularly transparent ones every 5-7 days. Gauze every 2 days. And scrubbing the connection port really well for 15-30 seconds before accessing it.
Scrub the hub. Got it.
Yeah. And sometimes, for high-risk patients, using special antimicrobial catheters.
What about older adults and IVs? Any special considerations?
Yeah, definitely. Their veins can be more fragile, so smaller catheters are often better. Their skin is thinner, so you have to be careful with tape and dressings. They're more prone to fluid overload, so careful monitoring of intake, output, weight, and breathing is crucial.
Circulation might be slower too.
Right, which can affect how meds are distributed. A useful tip: sometimes using a blood pressure cuff, inflated just a bit, is gentler than a tourniquet for finding a vein.
Then patient education is key here too.
So important. They need to know why they have the IV, what to look for signs of trouble like redness or swelling, how to care for the site if possible, and when to call for help, especially if they go home with a line. They need clear instructions and maybe practice.
Can you quickly compare peripheral versus central IVs?
Sure. Peripheral IVs, or PIVs, go into smaller veins, usually in the arm or hand. Short-term use, like a few days. Easier to put in, generally by nurses. Central lines, PICCs, tunneled lines, ports, go into big veins near the heart. Tip ends in a large central vein. Used for longer-term therapy, weeks or months, or for irritating medications. Needs sterile insertion, usually by specially trained staff or doctors. Placement confirmed by X-ray or ultrasound.
And require more specialized care.
Yes, strict sterile technique for access, specific flushing protocols, often with a 10 milliliter syringe using a push-pause method. Bigger risk of serious bloodstream infections, phlebitis with central lines.
What about managing common IV complications, like infiltration?
Infiltration swelling, no blood return, stop the infusion, elevate the arm, apply a compress, warm or cold, depends on the fluid.
Phlebitis.
That's vein inflammation, redness, warmth, pain, maybe a hard cord along the vein. Stop the 5, warm, compress.
Air embolism sounds bad.
It is. Chest pain, shortness of breath, low blood pressure. Immediately clamp the line, turn the patient on their left side, head down Trendelenburg and call for emergency help. Traps the air. Suspect it with fever, chills, Notify the provider, get blood cultures, start antibiotics if ordered.
And if the IV just won't flush, occlusion.
Don't force it. Check for kinks. Try a gentle flush. If still blocked, stop, notify the provider. Could be a clot.
Chapter 15 also mentioned other ways to infuse things, not just IV.
Right. Intra-arterial, usually in ICUs for monitoring or targeted meds. Intraperitoneal, into the abdomen for chemo or dialysis. Subcutaneous, under the skin for insulin, some pain meds, even fluids in palliative care called hypodermoclysis.
Interesting.
Into the bone marrow. Emergency access, especially if IVs are hard to get, like in trauma or kids. Intraspinal epidural or intrathecal for anesthesia or pain meds near the spinal cord requires strict sterile technique.
Any final key points from Chapter 15?
Using smart pumps for safety. OSHA safety devices to prevent needle sticks. The CRBSI prevention bundle is critical. Remembering older adult risks. Patient teaching. Choosing the right VAD vascular access device for the patient's needs. Consulting the VIV team if you can't get a peripheral line after a couple of tries. Good documentation. And knowing those other routes exist for specific situations.
Okay, shifting now to Chapter 9, perioperative care. Care before, during, and after surgery. Sound like a massive team effort.
It truly is. You've got the surgeon doing the procedure, getting consent, anesthesia managing sedation, pain, breathing, nurses assessing, educating, monitoring, advocating, pharmacists with meds, PTOT for recovery, dietitians for nutrition, social workers, case managers for discharge planning. Communication and smooth handoffs are everything.
What about getting the patient ready beforehand? The preoperative teaching.
Super important. Explaining NPO rules, when to stop eating and drinking, reviewing their medications, what to take, what to stop, especially blood thinners. Skin prep, like special showers, going through the pre-op checklist, ID band, allergies, consent signed, patient has peed, no jewelry or dentures.
And teaching them how to prevent problems after surgery.
Yes, things like how to cough and deep breathe, use that incentive spirometer gadget to keep lungs clear, why getting up and moving early helps prevent blood clots, doing leg exercises, maybe using compression devices, setting expectations.
Surgery can be stressful.
Yeah.
How do you help patients cope emotionally?
You assess their anxiety, offer support. Having family there can help. Explaining things clearly in ways they understand, answering questions, using calm communication. Just being present and empathetic makes a huge difference.
And after surgery, what's the focus of evidence-based care?
Pain management is huge, assessing pain regularly, using different types of relief, not just opioids. Preventing injury-safe positioning, side rails up, fall precautions. Preventing infection, sterile dressing changes, watching the incision, antibiotics if ordered.
Preventing other common issues, too.
Right. Preventing blood clots, DVTs with movement, compression, maybe blood thinners. Preventing lung collapse at atelectasis with deep breathing and incentive spirometry. Watching for urinary retention. Getting the gut moving again safely.
Malignant hyperthermia. You mentioned it earlier. Rare but serious reaction to anesthesia.
Exactly. MH. It's genetic. Triggered by certain inhaled anesthetics and succinylcholine. Causes this massive muscle reaction, rapid cheo-arrow rise, muscle rigidity, super high fever, fast heart rate, acidosis, hypotassium, muscle breakdown.
How do you prevent or manage it?
Screen patients for family history. Avoid trigger agents if possible. Have dantrolene, the antidote, immediately available. Use MH-safe anesthesia machines. Monitor very closely for early signs like rising cheo-arrow, heart rate, muscle rigidity. The high temp is actually a late, dangerous sign.
The chapter also described different nursing roles in the OR. Scrub nurse, circulating nurse.
Yeah. The scrub nurse is sterile, works right beside the surgeon, handles instruments, maintains the sterile field.
Okay.
The circulating nurse is not sterile, manages the whole room, patient positioning, paperwork, getting supplies, communicating outside the OR, kind of the coordinator.
And the laser nurse.
Specialized role for laser procedures. Knows laser safety, sets up equipment, monitors it, educates the team. Often the designated laser safety officer.
Any final big takeaways from Chapter 9 on perioperative care?
Use 2 patient identifiers, always. Get a full history. Report risks. Teach patients pre- and post-op care. Confirm they understand the surgery. Complete the checklist before any sedating meds. Communicate changes. Assess risks like infection, breathing problems, low blood pressure, blood clots, injury. Airway first post-op. Have suction and oxygen ready. Use anti-clot stockings or devices. Check the incision every shift. Aseptic technique for dressings. Early walking. Offer pain relief. Know how to handle wound opening evisceration or dehiscence cover with sterile, moist dressing. Position patient. Call surgeon immediately.
All right, that's Chapter 19, infection. Control the infections seems to start with knowing how they spread.
Absolutely. You tailor precautions to the transmission route, contact like MRSA, VRE, C. diff needs gloves and gown, private room ideally, spread by touch.
Droplet.
Bigger particles from cough, sneezes, flu, maybe COVID. Mask within about 3 feet. Gown gloves for close contact. They don't hang in the air long.
Airborne.
Smaller particles float longer, travel further. TB, measles, chickenpox, needs an N95 respirator for staff. Negative pressure room for the patient.
Vector-borne.
Insects, ticks, Lyme disease, malaria. Focus is on insect control, protective gear outdoors. And a key point. If you suspect something transmissible, use the appropriate PPE even before you get lab results back. Better safe than sorry.
Why are older adults often more susceptible to infections?
Several reasons. Their immune system naturally declines a bit, immunosenescence. Skin is thinner, less of a barrier. Chronic diseases can weaken defenses, more exposure in hospitals or long-term care. Maybe poor nutrition or hydration. Changes like less effective coughing or urinary retention can let germs take hold.
And their symptoms might be different.
Yes, that's critical. Instead of a high fever, you might see confusion, new fatigue, or just not acting right. Subtle signs.
So what are the absolute bedrock, evidence-based infection control practices in healthcare?
Hand hygiene, number 1. Soap and water if hands are dirty, alcohol rub otherwise. Using PPE correctly, gloves, gowns, masks based on the risk, using those HAI prevention bundles for things like central lines and catheters, strict sterile technique for invasive procedures, and antibiotic stewardship using antibiotics wisely to prevent resistance.
Did the COVID-19 pandemic teach us anything new or reinforce existing practices?
Well, definitely. It hammered home the importance of universal masking, distancing, airborne precautions when needed, the need for adequate PPE supplies, how useful telehealth can be, cohorting patients, strong surveillance, staff screening, and vaccination. It also really spotlighted health equity issues, how infection can hit some communities much harder than others.
How do you typically recognize an infection when assessing a patient?
Locally, you look for redness, warmth, swelling, pain, maybe pus or drainage. Systemically, think fever, chills, fatigue, high white blood cell count. And remember, in older adults, confusion might be the main sign.
Sepsis.
That's the body's extreme response. Low blood pressure, fast heart rate, fast breathing, low urine output, altered mental status, life-threatening emergency. And again, older adults might not have a fever even with sepsis. Mental status change is a key.
What about the superbugs, MDROs? How do nurses manage those?
The big focus is preventing spread. MRSA usually means contact precautions. VRE, same. Plus really strict hand hygiene, maybe limiting catheter use. C. diff needs soap and water, hand washing A's. Alcohol doesn't kill spores and bleach for cleaning surfaces. CREKPC, also strict contact precautions and careful antibiotic use. Monitor closely, educate patient and family.
And managing fever if someone has a systemic infection.
Watch the temperature trend. Give antipyretics like acetaminophen or ibuprofen if ordered. Push fluids orally or IV. Monitor for sepsis signs. Maybe cooling blankets for very high fevers, but cautiously. See how they respond to antibiotics. Check culture results.
So wrapping up Chapter 19, what were the key messages?
Older adults, high risk. Know the transmission modes contact, droplet, airborne. HAIs unfortunately increased during COVID. Health equity is vital. Teach everyone basic prevention, hand washing, vaccines, avoiding crowds when sick. Use standard and transmission-based precautions. PPE is a barrier. MDROs are serious. Fever is a priority problem in systemic infection. Treat with antibiotics and fever reducers.
Wow. This has been incredibly thorough. It really drives home how interconnected everything is. Fluids, electrolytes, acids, bases, safe infusions, surgery, infection control. It's all part of keeping the body in that delicate balance.
Absolutely. And understanding the subtle signs, that slight confusion in an older person signaling infection or how a small potassium shift can impact the heart, it highlights the skill involved.
It really does. Our goal was to give you, our listeners, solid, understandable information on these complex topics. We hope this deep dive has done that.
It makes you think, doesn't it? Considering this intricate balance we've talked about, what small things in your own daily routine, maybe how much water you drink, your diet, even hand-washing habits, might actually have a bigger impact than you realize on keeping everything running smoothly? Something to ponder.